We are talking about cardiomyopathy, which is one topic in CVS cardiovascular system, talking about the pathologies of the heart. So, by definition, what is cardiomyopathy? The 2006 American Heart Association defined these cardiomyopathies as heterogeneous group of diseases of the myocardium, where you have got either mechanical and or electrical dysfunction. So in other words, you can have mechanical dysfunction, electrical dysfunction, or both of them at the same time. And you are going to have inappropriate ventricular hypertrophy, or the ventricles are going to end up dilating due to a lot of causes. Sometimes, and actually most of the time, these causes can be genetic. So cardiomyopathy, this is a disease of the heart muscle in which the heart loses its ability to pump blood effectively. The heart muscles become enlarged or abnormally thick. If the muscles are thick, they will become rigid, like it's a bit of hard for them to contract. Okay. In rare cases, the muscle tissue in the heart can also be replaced by scar, and scar tissue cannot contract. So as cardiomyopathy does progress, the heart will become weaker and less able to pump blood through the blood or throughout the body. And that is going to lead to heart failure, arrhythmias, systemic and pulmonary edema, and more rarely endocarditis can also develop. What are the risk factors for someone to be able to develop cardiomyopathy? A family history of cardiomyopathy, heart failure, or sudden cardiac death. Someone just dies. So this can be a risk. Also, having a disease or condition that can lead to cardiomyopathy, for example, coronary artery disease, a previous heart attack, the inflammation of the myocardium, myocarditis, also diseases that can damage the heart. For example, hemochromatosis. This is where I've got too much iron, like hemo, in the body. Sarcoidosis also, amyloidosis. This is where having different types of proteins being deposited in the heart. Also, long-term alcoholism, long-term high blood pressure, diabetes, and other metabolic diseases. These can be risk factors for developing myocarditis. We have got three main types of myocarditis, but first, we can divide myocarditis into primary myocarditis and secondary. Primary, these are the ones that result from genetic abnormalities of the heart. And this is where you find the three main types: the dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy. Secondary cardiomyopathies, these ones result from infections, not really from the. Remember, every time you're talking about primary, it means that the problem is really affecting that same organ or starting from that same organ. But secondary is resulting from things like infections, metabolic and nutritional diseases, all these chronic heart disease, hypertension, endocrine disorders, neuromuscular disorders, blood diseases, tumors. Okay, different things. So cardiomyopathies are either confined to the heart or they can be part of the systemic process, like you have got a systemic infection, not only affecting the heart, and this can lead to progressive heart failure. So starting with dilated cardiomyopathy, what is the problem here? The heart is failing to contract to push blood. And if the heart can't contract to push blood, what is going to happen is that there's going to be a reduction in cardiac output. When there's a reduction in cardiac output, because there's little blood flowing in the blood vessels, there's going to be reduction in blood pressure. And that actually leads to increase in systemic vascular resistance, right? Like blood, think of a hose pipe where water is flowing slowly, so there is a higher resistance in that case because of the slow speed. So there's increase in systemic vascular resistance, and what the body is going to be trying to do is to compensate for that reduced systemic vascular resistance or the decreased cardiac output. So it will now start bringing a lot of blood back to the heart, a lot of blood coming back to. That is going to be an increase in preload. And as the preload increases, what is going to happen is that the ventricles are going to end up dilating so that you can be able to push this blood, which is a lot, away. And as that is happening, the muscles are going to become thicker, and as the muscles thicken, the ventricular chamber size is also going to increase. Okay, so take note what's happening. The ventricular mass chamber, the chambers are increasing because of these a lot of blood that is coming in, and over time the heart is going to become weak because you can't accommodate all this blood that is coming. That can lead to heart failure with reduced ejection fraction. So the heart is failing to pump blood. Okay, ejection fraction is the amount of blood that is pushed out of the heart. So the fraction of blood that is pushed out of the heart is going to reduce because the heart is failing to push out that blood. And in dilated cardiomyopathy, there is eccentric hypertrophy of the heart. The heart chambers dilate. Please take note, chamber, okay, not muscle. The heart chambers dilate while the wall is going to, the wall thickness is going to decrease or remain the same. Please take note of this. The chambers are bigger, but the walls are either the same or they have reduced in size. This can also lead to problems of the heart valves, and it can cause regurgitation, blood going back into the blood vessels where they are coming from. That's regurgitation. It can lead to arrhythmias. It can as well lead to blood clots because of the poor blood flow. And if this happens, it can be a need for performing a heart transplant. So, what is happening? There is actually inflammation and rapid degeneration of myocardium. Because of this, that is going to cause the ventricles to be able to dilate. When they dilate, there's going to be impairment of systolic function. The heart can't pump blood out. Okay. The left atria is going to enlarge, and the stasis of blood in the left ventricle. Blood can't move from the left ventricle. That actually leads to a big heart, cardiomegaly. You can see here the ventricles are very, very much like the chambers themselves are very large. The walls can be normal or can be reduced. What are the complications of dilated cardiomyopathy? Dilated cardiomyopathy can lead to heart failure, as we said earlier on. You know, heart failure, you have got left-sided heart failure and right-sided heart failure. So for the left side of the heart, you know, the left side of the heart, this side, pumps blood to the rest of the body. The left side of the heart receives blood from the lungs. So if the left side of the heart is failing, what is going to happen is that blood can't be pushed to the rest of the body. What happens? There is a stasis. Blood is going to power up in the left ventricle. It will start going back to the lungs. So in left heart failure or left-sided heart failure, blood is going to back up to the heart because of reduced cardiac output. It goes back to the pulmonary capillaries. When it goes back to the pulmonary capillaries, because it's too much, the blood will start moving out to the capillaries, going into the lungs, causing pulmonary edema. And this can manifest as paroxysmal nocturnal dyspnea, shortness of breath that occurs suddenly, and it will cause a person to wake up. Okay? Paroxysmal nocturnal. Nocturnal is when you are sleeping, isn't it? So someone ends up waking up to catch a breath, or it can manifest as orthopnea. This is where someone is trying to catch a breath. Okay, trying to catch a breath. So in left-sided heart failure, the problem is with the lungs. There's pulmonary edema, paroxysmal nocturnal dyspnea, orthopnea. And then heart failure. Here, remember the right side of the heart receives blood from the rest of the body and pumps that blood also to the lungs. But because the right side of the heart is failing, blood is going to continue going backwards to the rest of the veins in the body. So if the blood goes back to the hepatic veins, it is going to lead to hepatomegaly. If it goes back to the peripheral veins, it will lead to peripheral edema. It goes back to the veins that are part of the abdomen here, it was going to lead to ascites. these veins will be ending up distending, right? And blood will be coming out of them. And actually, this ascites can be a very good way because these blood vessels are found like the portal vein. This is connecting to the GIT. So bacteria can also end up moving out and going into the peritoneum, leading to spontaneous bacterial peritonitis, which is a very bad complication of this ascites. If the blood also flows back to the carotid this jugular vein, it is going to lead to jugular venous distension. So there's an increase in jugular venous pressure. So that is going to give what is known as a Kussmaul sign, which is a sign where you have got the jugular venous pressure being increased when someone breathes in. You breathe in, the GVP increases. So that is about dilated cardiomyopathy. Please, if there's any question, we can get to ask there. The second one is hypertrophic cardiomyopathy. From the word hypertrophic, here what happened is that it occurs when the heart muscle thickens abnormally, specifically the left ventricle. It has got some other names like idiopathic hypertrophic subaortic stenosis, muscle subaortic stenosis, hypertrophic obstructive cardiomyopathy, but not much to worry. So the hypertrophic cardiomyopathy is of two types, the obstructive type and the non-obstructive type. So in the obstructive type, what is happening is that the septum, the middle part of the heart has thickened. Okay. When the septum thickens, it's going to be able to bounce into the left ventricle. So what happens is that the left ventricle is going to be blocked. So there's block of the left ventricle. So blood can't move into the, and because of that, there is ventricular outflow tract obstruction. The outflow is the part where blood leaves these ventricles going into the big arteries like the pulmonary artery or the aorta. So there is an obstruction there, specifically on the left side, and that will lead to the ventricle trying to do a lot of work to be able to push blood into the aorta. And as that is happening, the heart is failing. It can't really sustain those contractions. So here in dilated cardiomyopathy, we said that there is eccentric hypertrophy. Here there's concentric hypertrophy, the thickening of the ventricular wall. There we said that there was a thickening of what? The ventricular chambers. But here the wall are thickening with normal or reduced chamber. You can see the opposite side, opposites. Some signs you can see is pain, chest pain, dizziness, shortness of breath, fainting. It can also affect the mitral valve, and that can cause blood to leak backwards. Okay, regurgitation. In the non-obstructive type, here it is not only the septum that thickens, but the entire ventricle may become thick. Symmetrical ventricular hypertrophy, or it may happen only at the bottom. That's known as apical hypertrophy. The right ventricle in this type can also be affected. So what happens really? There is a thickened intraventricular septum and ventricular wall. When this thicken, the ventricles have been, the outflow, ventricular outflow tracts have been obstructed, and so the ventricles hypertrophy in order to push blood away, and that is going to lead to diastolic dysfunction. Like the ventricles can't accommodate blood, they can't relax because they are thick, they are small chambers, and that leads to impaired feeling, right? And obstruction to the decrease due to obstruction, that leads to decreased flow. And because of this, because the ventricles are small, they can't get enough blood. So even what they pump out is small, there's decreased cardiac output. So you can see of importance here is there is a septum dilating. You can see the chambers have become small, specifically on the left side. Symmetric or concentric hypertrophy. What can cause hypertrophic cardiomyopathy? It can be inherited disorders, acquired disorders, or even some which are idiopathic. Or, for example, an autosomal dominant inheritance. So there is what is known as a heavy chain myosin gene mutation. So basically, these are more inherited. There are these mutations in the heavy chain of myosin. Some environmental factors can also get to contribute, though unclear. How does it happen? What is the pathophysiology? You are going to have left ventricular outflow obstruction, diastolic dysfunction. Because of the obstruction, the ventricles have become small, so blood can't be able to come in the ventricles. And because of that, blood can't be pumped to the rest of the body, including blood can't go to the heart itself. Why? The ventricles have become big. So the arteries that are supplying the heart itself, they have got only to what extent they can supply the heart. So there is some of those parts of the tissue that can be supplied because of dilated. So there is ischemia because there's no blood going there. Because the valves can also fail, there's also regurgitation that can happen, mitral regurgitation to be specific, because on the left side, clinical presentation of hypertrophic cardiomyopathy, dyspnea on exertion, like when someone is trying to exercise, they are failing to breathe, orthopnea, also paroxysmal nocturnal dyspnea, also angina, pain. Why is the pain happening? Because the heart is not receiving blood itself. Someone can faint, ejection, systolic murmurs. Stroke can also happen because blood is not going to the rest of the body. Same with the brain, it will not be receiving enough blood. Okay. Actually, hypertrophic cardiomyopathy is the most common cause of these deaths in young people, including the athletes. So just here, someone, you guys watch football, so you should understand this. Someone football, just search. There are a lot of people that have died on the pitch. Someone is just exercising, they just end up failing. That is because hypertrophic cardiomyopathy can lead to cardiac arrest. Okay, because of the arrhythmias that come about. So someone will just end up falling, they die like that while they were normally exercising. How do you diagnose? You can use an ECG, electrocardiogram. You want to look at abnormal ST waves. You can also do an MRI. So sudden cardiac death can happen in hypertrophic cardiomyopathy. It's more frequent in the young adults, 30 to 35. This is primarily because of the ventricular fibrillations or the ventricular tachycardia that can happen when someone is not receiving, the heart is not receiving blood. Okay. So the patient will tend to die during or just following vigorous physical exercise. Just there, the heart is sudden heart attack and they just end up falling after the first clinical manifestation of the disease. The risk factors for hypertrophic cardiomyopathy, I've got the major ones: intense competitive physical cardiac arrest. So these family history, unexplained fainting, these can be risk factors. Okay. You can see in hypertrophic cardiomyopathy, the ventricles have become really, really small. You can see the septum very, very huge. Complications of hypertrophic cardiomyopathy, because we have said that the ventricles have become small, so even the ability to push blood to the rest of the body has been reduced. Because of that, what is going to happen is that there is a reduced systemic perfusion. Blood cannot go to the rest of the body. So you can actually use a mnemonic SAD. This will represent the complications. They have got syncope, that is fainting, because blood is not going to the brain, reduced perfusion to the brain. There is also a, which is angina, because blood is not actually going to the heart, so the heart tissue starts, the heart muscle starts to die. There's ischemic heart disease, that's angina. It can also, murmurs can also happen, ventricular tachycardia and fibrillations, which are the ones responsible for certain death, can also happen. And then the D there is dyspnea, because what is happening is that blood can actually start going back to the lungs because it can't be pumped to the rest of the body. And so there's pulmonary edema that causes dyspnea because there's going to be obstruction to the respiratory system. The last type of cardiomyopathy, which is primary, is restrictive cardiomyopathy. And this one is a result of myocardial disease. What of importance here is that in restrictive cardiomyopathy, there is no dilatation of the ventricle, okay, no non-dilated ventricular, left ventricle, diastolic dysfunction. This is the hallmark. There's the dysfunction of the ventricles, but then they are not dilated. In the restrictive cardiomyopathy, it's not always isolated cardiac disease, but it's in other words not common. It can arise due to some acquired or genetic diseases. I didn't mention the the first type, the dilated cardiomyopathy. I didn't mention what can cause them. I'm going to mention them later on. But in restrictive cardiomyopathy, what is happening in here is that you have got increased stiffness of the myocardium. If the myocardium is stiff, what happens is that when blood is trying to come back to the heart, it has got no place where it can really stay, right? There's no place where the blood can really stay. And that is going to lead to impaired diastolic feeling. So the ventricles can't feel. Okay. Systolic function is normally preserved. Like you can normally pump blood out of the heart, but the problem is that you can't receive blood because of the stiffness. So there is poor ventricular compliance. The ventricles can't really relax to allow blood to move out. So how does restrictive cardiomyopathy happen? There is some form of infiltration. Some proteins have infiltrated themselves into the ventricles, and so the ventricles can't expand. They can't expand. There's actually no hypertrophy here. So some infiltrative diseases that can affect the heart. Of course, some of them affect other body parts, include amyloidosis, where there's a buildup of abnormal amyloid, sarcoidosis, where you have got immune complexes being deposited in different regions or in different parts of the body, in the kidney, in the liver, including in the heart, hemochromatosis, abnormal iron. So these guys can all infiltrate in the heart, and that will cause the heart to not be able to relax. Okay, the pathophysiology is some etiological factor that will lead to stiffness of the ventricle. The ventricle, there is reduced compliance, so the ventricles become resistant to feeding, and there's reduced cardiac output. And we have got different classifications of restrictive cardiomyopathy. We have got the idiopathic one, the non-infiltrative, infiltrative, and such. So how can you diagnose this? You can use an echo. You look at the non-dilated, non-hypertrophic ventricles. You can look at an ECG. There will be different ECG changes. The treatment here, you want to treat the cause. There is no really any satisfactory medical therapy. You can use some diuretics so that reduce on some fluid, calcium channel blockers to improve on the diastolic compliance. You can also do a heart transplantation, digitalis, and other inotropic agents. These ones you not use them. Okay, these guys help in contraction of the heart, so not give them. Before I talk about the complications, I was saying dilated cardiomyopathy can be caused by a lot of things, but I didn't mention the causes. Alcohol can cause dilated cardiomyopathy. So sometimes we are going to say alcoholic cardiomyopathy is actually a type of dilated cardiomyopathy caused by alcohol. Beriberi also, where we've got thiamine deficiency, you also have different things. So we can simply use the letters A, B, C, D. So A is alcohol, B is beriberi, C can be cocaine toxicity or Chagas disease caused by Trypanosoma cruzi, right? So those can be the causes, and also another C can be the Coxa B virus, and then the D is going to be the doxacarbilin. At least you can know the alcohol is the most common. You can also learn of the beriberi, Chagas disease. So what are the complications of restrictive cardiomyopathy? They can also be heart failure, the left heart failure, and the right sided heart failure can happen. The same things that we talked about earlier on. Okay. So that is basically that on cardiomyopathy.